Right, live to YouTube. Here we go. Right, live to YouTube. Hi, good evening and welcome to this CPD Me webinar. My name is Andrew Ormrod and I'll be facilitating the webinar tonight, and I will very shortly be handing you over to our very own Dr Akash Doshi talking arterial blood gas interpretation. So I can see people are already engaging in the chat. You have got a couple of options up there. You've got a chat and a questions and answer box. If you have any questions for Dr. Akash, then please do pop them into the Q&A box and I will line them up perfectly for the end. If you are using the chat, please pop in the chat, tell us where you are dialing in from tonight, maybe what you do for a living. I can see already we've got David there from Staffordshire Moorlands, and we've got Pure from Good Evening, and Lord Alan. Evening, Alan. Walter from Cheshire, and Emma, paramedic from Norfolk. So please do pop in there where you're coming from tonight, what you do for a living. Also maybe really useful is what's brought you here tonight around arterial blood gas. If you are a member of CPD Me, then we will drop you a CPD certificate, and that will automatically drop into your CPD Me portfolio. And at the very end of tonight's presentation, I'll show you a little guide video of our amazing app and how that works and how it drops in. And then all you need to do is dictate and reflect. And then it makes recording CPD super simple. I've been a paramedic for a few years now and designed it purely because I had friends of mine who were not able to build portfolios for the HCPC. So back in 2009, I ventured upon a research project and there was born CPD Me. Who would have thought it? We didn't have webinars back there then. In fact, I don't even think webinar was an actual word. But CPD certificates will go out to members tonight and they will drop into your portfolio. And then, of course, everybody will get a copy of the recording and that will come automatically to you 24 hours after tonight's event. So if you have to shoot off for whatever reason with your on call, or whether you're having your tea mid-webinar, then you'll get a copy of the recording tomorrow. Lots and lots of people up there. Andy, evening Andy, paramedic in Edinburgh. Good evening Edinburgh. We've got Sue from Newcastle. We've got Sean, who's a specialist paramedic from Newcastle. Dan from Merseyside. Hi Dan, I've done my time working down there at your fancy estuary point. Staff nurse from Fort William, Katie. Good evening Katie. And we've got Adrian from God's own country. Good evening Adrian. Oh, lots of people. Paramedic from Cardiff, Ross. So there is some opportunity to scan QR codes tonight. So if you have got a QR code scanner on your mobile, then you can simply point it at the screen and we can go through there as we need. If you're on Twitter, please do share what you're up to tonight, whether you're relaxed learning at home or indeed you are doing something else. But if you tag us in with hashtag CPD Made Simple and at Twitter at CPD Me, I will follow and like you later on while Dr. Akash is doing his stuff. Just for votes up, just let me know who are members, because it's always interesting to see in the chat who are members. Just type yes or no if you're a member of CPD Me and whether you find our CPD portfolio building useful. I'm sure there'll be yes, yes, yes. Gosh, I can't even see that moving too quickly. But we really have got the easiest and most simple way to record your CPD. So if you're not a member, we've got a great offer and that allows you a 30-day full premium access for £1.99. You can't even buy a coffee for £1.99. The price after that, it's £15.99 per year, and that gives you full access to the CPD recording system and up to 80 live broadcasts or CPD activities per year that automate certificates into your portfolio. So it really does make sense. If you haven't joined, please do scan that QR code. It's £1.99 for a month. If you don't like it after that month, I'll even arrange for you to have a refund for that £1.99. I'm that confident that you'll like it. And speaking of confidence, please do leave us a genuine review on our Trustpilot page, on our Google page, or via our apps. I'm just going to pop these links now into that chat. Thanks very much all you guys there who said that you use the system. Eileen, best CPD on the market. Thank you, Eileen. And I've not even sent you a complimentary mug to say that in the chat. But please do leave us some genuine review on Trustpilot, Google, or the App Store. And I have got 4 books to give away tonight. Let me just show you these books. I've got 2 copies of the pre-hospital care manual. And I've also got 2 copies of Clinical Skills and Introduction for Nursing and Healthcare. And speaking of which, I have actually got the authors of this book coming on board in January to do a webinar for us, Dr. Robin Richardson and Joanne Keeling. So they're going to come and talk about the book, and we'll also have some giveaways then. So please do leave us a review. If you leave it before the end of the webinar, I'll have a quick peek and I'll give 2 away tonight. And I'll advertise. In fact, I'll tell you what I'll do. I'll open your microphone up at the end of the webinar, and then 2 more I'll choose offline tomorrow when the team come in. So please do leave us a review. And if you do follow us on YouTube, please do subscribe, because every time we go live, we also go live to YouTube, because we often fill these rooms up very quickly. I think tonight we had a couple of 100 people registered, but we do fill up really, really quickly. So if you ever struggle to get onto our live webinars, please do jump onto our YouTube channel, because we always stream onto there. If you haven't downloaded our CPD poster, please do so. You can again scan that QR code, or you can grab it from our CPD.me website, and that will list all of the posters for the up and coming month that you can post at work, share electronically, pop on the back of the toilet door, or in your learning zones. But it's a great way to share these free learning experiences and webinars with your friends and colleagues. All that leaves me to do now is hand over to the main event. So are you there, Dr. Akash?
I am. Hi.
Fabulous. I'm going to hand the screen and the mic and the platform all over to you.
Excellent. Thank you. Lovely. Can everyone see that? Excellent. So I'm going to be talking about arterial blood gases, and I'm really going to aid the interpretation here with some cases. So I think that's what's going to really help make it much more solid for everyone. This is me. I'm a specialist registrar in endocrinology and diabetes, but also general internal medicine. As a result, I cannot stress the amount of blood gases I look at, anything between 25 and 50 plus a day. And so blood gases are very much my go-to whenever I'm looking for any sort of test. I think genuinely they are the most useful test I can get on a patient. So what we're going to take you through today, we're going to take you through an introduction to ABGs and VBGs. We're going to talk about how to interpret. And we'll finally take you through some cases where it really helps reinforce the knowledge that you're getting. So what is a blood gas? Originally, a blood gas was really only to measure the blood gases. So PO2, PCO2, and either we can get it from venous blood or we can get it from arterial blood. But these days, they give you a wealth of information, so many more parameters, depending on where you are. So that usually includes all your electrolytes, sodium, potassium, chloride, calcium, includes base levels, which are calculated through your bicarb levels, glucose, hemoglobin, lactate, and sometimes even creatinine. The bicarb and the base deficit are calculated values. They are not actually measured on the gas. To be honest, that it doesn't really impact you in any way. It's just something to bear in mind. So what are the differences between a venous blood gas and the arterial blood gas? I think this is a really common question, because people are like, well, should I do an arterial one because I don't trust the venous one? I think this kind of helps you understand what you're looking at. So the VBG will have a slightly lower pH. The lactate will be slightly higher. The PO2 will be lower, and the PCO2 will be slightly higher. The important things here are, so if you've got a normal pH, well, then you know that the patient can't possibly really be acidotic, because on the VBG, it's slightly more acidotic than it is on the ABG. Similarly, the PCO2. If you see that the PCO2 is normal on a venous blood gas, that's actually really helpful information, because that means it must be normal on the arterial as well, because the VBG is higher than the ABG. The differences are quite minute, but the problem is these differences vary. And they'll vary in that the more unwell your patient, the higher the difference. The reason being is if you're unwell, you're going to be essentially going through more metabolism, more shock, more lactate, more anaerobic respiration, which means that these values, these differences are a bit more. But as you can see, the differences are very minute. The pH is barely any different. The lactate is hardly much different. And the PCO2, again, isn't considerably different. The PO2, though, does vary a lot. And we'd expect this because essentially we're hoping that the arterial supply is supplying oxygen to our body and it's being taken up out of the blood, because otherwise there'd be no point in our circulatory system. But as I said, things are a bit more different if your patient is shocked and unwell. So with that in mind, when should we be using a venous blood gas? When should we be using an arterial? Well, I can't advocate that we really should use venous blood gases much more than we often do. And actually, there are a lot of times when a venous blood gas will be enough, and we don't actually then need an arterial blood gas. I'd advocate that every patient attending A&E really should have a venous blood gas. I mean this in terms of any patient attending the kind of main part. I don't mean UCC and other kind of GP-led services. I mean, if you are coming because you are genuinely unwell, then a venous blood gas is really helpful to sort out the sick from less sick. It's being increasingly used in pre-hospital care, and I think that's why we're joined by so many paramedics and so many people who do all of that. And it's also really helpful for monitoring patients. So intensive care, whilst the patient is an inpatient, we will do regular venous blood gases, monitoring the differences to see whether our interventions are working. An arterial blood gas is much more painful. And there are some strategies against that, but overall it's much more painful. So the main use is really when you're assessing three things. One, oxygenation. So in a patient who is hypoxic and their SATs are below 92%, this is as per the BTS guidelines, British Thoracic Society, with signs of respiratory distress, that is when you would consider doing an ABG. Another situation might be if they've got features of hypercapnia, because you want to confirm that they do have hypercapnia. Ruling out hypercapnia, the venous blood gas can be very helpful, because essentially if it's normal, then it's normal on the arterial. But ruling in, you really want to use an arterial blood gas. And finally, those who are severely shocked. The reason being is that you can't rely on the venous blood gas so much as we described in the previous slide. So, tips on arterial blood gases. First of all, consider whether a VBG may give you the answer that you're looking for. So I usually won't suggest doing a ABG to measure the pH because you're not sure whether the VBG is reliable or not. In most situations, that won't change the management of your patient in front of you. Additionally, what I mentioned about the PCO2. When you are getting an ABG, it's important to record the patient's temperature. This will impact of how basically your oxygenation, your PO2, your PCO2, and so putting the right temperature in the machine will correct for that difference. And I think this is something we regularly don't do. And importantly, our septic patients are often very pyrexial. And they're the ones that we really want an accurate gas on. And also record their oxygen, because the amount of oxygen you're giving them will dictate how you're reading the gas. If the blood gas looks normal, but they're actually on really high volumes of oxygen, well, actually that blood gas isn't normal because the patient should have really, really high levels of PO2. Multiple sources, including UpToDate, questions the validity and reliability of the Allen's test. For those who are aware of the Allen's test, it's where Essentially, we're looking at whether there's peripheral, whether there's both radial and ulnar circulation to the hand. Your concern being is if you accidentally go through the radial artery and end up causing quite the thrombus there, you may lose blood supply completely to the hand if the ulnar supply can't take over. But actually, in practice, very few people do this because it's of questionable reliability, and that you can't really accurately assess it by using the Allen's test. So I won't go into that in much more detail. I very much recommend using local anesthetic cream or gel or local infiltration. Obviously, this is difficult because the anesthetic cream or gel needs to be on for a good 30 minutes before you can do it, which means, and in most cases, emergencies aren't planned emergencies. I mean, that's the definition of the word emergency. But for example, if you've got a patient who's had a blood gas, they've developed type 2 respiratory failure and they've started NIV or BiPAP or something, well, then you know they're going to need regular gases. So you could do the first gas, but then after that, you really should be giving them something to numb that area so that subsequent gases don't hurt so much. You can also consider local infiltration. And by giving that very, I think it's really useful for patients who you can't feel a very good pulse, and who you think actually it's going to take a little bit of time or difficulty or multiple attempts to get that gas. Arguably, some patients won't want 2 needles, so one to do the infiltration and one to get the ABG. But those who are going to have multiple needles may well want that one extra one to prevent so much pain on all the subsequent ones. But ultimately, you're feeling for the strongest part of the pulse, you're putting fingers either side, and then you're going in at 90 degrees. And I think that's the easiest way. Some people like to feel the pulse and kind of go underneath where they're going with their finger, which also works. It's just my preference has always been to feel each side and go in between. So, blood gas interpretation. So I could not find an acronym whatsoever to take you through the blood gas interpretation method. So I decided to just invent my own. So tell me in the chat whether you think this is any good or not. But I've gone for CHARMA just because why not? So CHARMA stands for Clinical Hypoxia Acid Alkali Respiratory Metabolic ELS Response. And so this is a nice, easy way of just thinking about how one would interpret a gas. So what I'll do is I'll take you through each of those and explain a little bit more about what each of them mean. So clinical. It is really vital to know what your patient is like before you interpret the gas, because the gas is interpreted alongside the patient in front of you. For example, if the patient's got COPD, well, A, you're going to pay a lot of attention to PCO2. B, actually, you might accept that a degree of hypoxia may be normal for that patient. Furthermore, if the patient is on 15 liters of oxygen via non-rebreathe and their PO2 is 11, you'll say, well, actually, that's not a normal PO2 because I'd expect it to be a lot higher. And so that's an important thing. The other thing is, does it sound like it's a lung or a metabolic problem or another problem? Because people can get their heads wrapped around working out exactly like all these complex things, like, well, is it the easy things being like, is it a respiratory metabolic acidosis? But then if it's a metabolic acidosis, well, is it anion gap? Is it non-anion gap? Well, actually, you can go down all of those fancy things, but in clinical practice, really, we just ask the patient what's wrong with them. And 9 times out of 10, that will tell us what the reason for the metabolic acidosis is, far better than using all these fancy calculations. So stress, clinical is the most important part of the gas, and it will tell you much more than the gas will. Hypoxia. So the normal PO2 is about 10 to 13. We define type 1 respiratory failure, where essentially where there's hypoxia or one thing wrong, as a PO2 of below 8. That said, it will depend on how much oxygen the patient is on. And what we say, normal is about the FiO2 minus 10. So by the FiO2, what I mean is the flow of inspiratory oxygen. So for example, a non-rebreathe mask gets about 80-ish%. Your Venturis tell you what percent. Your nasal cannula can be quite variable, but around about 28%. But ultimately, that minus 10 is a quick and easy tool to work out roughly what you're expecting the PaO2 to be. I say this saying that basically, if you've got a person receiving 15 liters of non-rebreathed oxygen, well, you're expecting a PaO2 of way above 40. And so if you are getting a PaO2 within the normal range, that is abnormal. And that is type 1 respiratory failure, because to be giving that degree of oxygen to the lungs and still be getting only just about in the normal range, well, that's wrong. Type 2 respiratory failure, just because we're talking about type 1, is where the PCO2 rises. It's where two things are wrong. It is twice as bad. I've gone through missed a couple of slides there. So acid alkali. So the first thing to look at is what is the pH, and helpfully it's normally the first thing on the gas. Below 7.35 is acidotic and above 7.45 is alkalotic. And what we need to bear in mind is that the CO2 is acidotic. And so when you've got more carbon dioxide, i.e. you make more carbonic acid, that will reduce the pH, causing acidosis. And the base is alkali. Therefore, if your bicarb is going up or your base is going up, then the blood gas will show a more alkalotic value. And that aids interpretation of whether it's respiratory or metabolic. Some people like to use Rome. And so that's respiratory opposite, metabolic equal. So the way to look at this is basically if your pH is going up and your PCO2 is going down, well, your pH going up is alkalosis. If your PCO2 is down, then that suggests it's a respiratory problem. Whereas if they're both going the same direction, i.e. your pH and your base are going both up, then that's metabolic because it's equal. And vice versa. So the pH going down, the PCO2 going up is acidotic. Whereas if both are going down, it's a metabolic acidosis. So that's one way that people like to learn it. Although sometimes I think in the heat of the moment, this can be a bit difficult. But see whether this suits you when you're next interpreting your gas. The other way to look at it is basically just think through things. So from the pH, we know whether it's low or high. If it's low, we know it's acidotic. And the next question is whether it's the PCO2 or the base causing it. So we start always with the PCO2 because we go for CHARMA, the R. And we see, well, is the PCO2 high? Because that's what we would expect if it was the respiratory thing that was causing the acidosis, because we know that carbon dioxide is acidotic. It is high. Okay, well, it's respiratory acidosis. It is not high. Well, let's have a look at the base then and see if that's low. Because we know that the bicarb or base is, well, basic. It is alkali. And so if it's low, that suggests it's a metabolic acidosis. In contrast, if the pH is high, well, we then know that the patient is alkalotic. What we'd expect if it was the respiratory alkalosis is that the carbon dioxide would be low. Therefore, if we see that, we know it's a respiratory alkalosis. Alternatively, it would be if the bicarb or base was very high. If that's the case, well, then we've confirmed that it's a metabolic alkalosis. So this is another way of looking at it. I'll briefly mention compensation, but actually in real life, it doesn't impact our management so much. But essentially, if the patient has got an a respiratory acidosis, well, then what the bicarb will do is the bicarb will try and go up to offset this acidosis, to basically equalize the pH. So that's what we mean by compensation. Whatever the case, one of these things will try and do the opposite. If it's a respiratory problem, the metabolic system will compensate and vice versa. For example, if the patient has a respiratory acidosis, well, then over some time, and it takes a day or so for the kidneys to do this, they will increase the bicarb or the base to bring that pH back down. Sorry, to bring the pH up, I should say. Apologies, that's a mistake there. But ultimately, to try and compensate for this, the body will compensate to a degree, but what it won't do is compensate completely. So the pH will be at the borderline low or low. And it also takes some time for the kidneys to do this. Vice versa, the respiratory system tends to be pretty quick. So if you've got a patient with a metabolic acidosis, they will breathe deeper and heavier to try and get rid of their carbon dioxide to bring their pH back up. We call this Kussmaul breathing. You often see it in patients with DKA and other things causing metabolic acidosis. But in real life, even if you don't understand what this compensation thing is, arguably in real life, it doesn't really commonly change our management. And so it's not something that you really do need to completely get. Anion gap is another thing. But once again, it's rarely helpful in real life. I don't think I can think of at all a single situation where the anion gap changed my management of a patient. The cause is usually obvious. So it's usually quite obvious the patient has got a DKA because on the gas, you've got a really high sugar. The history of an overdose, if you've got a patient who you're not sure what's going on, then / they were found with a lot of pills behind next to them, or they are known for previous psychiatric history or suicidal attempts. Usually overdose, you can get some sort of an idea that you might not know what they've had, but you can get an idea that they've had something. AKI tends to be fairly obvious on the basis the patient either looks dehydrated, isn't passing the urine when you put the catheter in, or often these days the gases can come with a creatinine, which will just tell you that this is the diagnosis. And then finally, again, the lactate is often on the gas and telling you that the patient's got a lactic acidosis. Essentially, metabolic acidosis, though, to understand what an anion gap is either due to a high chloride, low bicarbonate, or others. And so what an anion gap is doing is basically assessing these two parameters and seeing whether they're enough to explain the pH or whether there must be another source. And if there's another source, the anion gap can identify when this is. And so what we do is we take away the chloride and bicarb from the sodium to work out the anion gap. And a normal anion gap is less than 12. Because essentially we know that there are a couple of more anions that we haven't really measured here, which are normal and physiological. And if you add that in as well, then it will be 0. But we use these because they're nice and simple and you get them on the gas. If it is normal, well, then these are your causes, essentially things that are going to really interrupt these two systems. So adrenal insufficiency, bicarb loss, chloride excess, diuretics. But in all honesty, you're going to see the fact that the patient is having things that are going to cause you to lose your bicarb or cause excessive chloride, or you're going to know they're on diuretics. And for your patient's adrenal insufficiency, well, they're also going to be hypotensive, hyponatremic, potentially hypoglycemic. There are going to be other clues which are readily more obvious than the anion gap. In contrast, if the anion gap is abnormal, i.e. it's a high anion gap, i.e. above 12, you're thinking mud piles, and there's a couple of other acronyms as well out there which you can search. Methanol, uremia, DKA, paraldehyde, isoniazid, lactate, ethylene glycol, salicylates. Ethylene glycol is antifreeze, by the way. Essentially, you're going to know usually if your patient has got kidney failure or DKA because the high glucose, they've taken some sort of substance, or the lactate is high. So usually you will know. Often the newer and fancier blood gas machines will automatically tell you what the anion gap is. Otherwise, if it doesn't, then you're just going to use MD Calc or something, at which point it's going to tell you it is high or it is low, at which point you are just going to plug it in causes of high anion gap, and it will give you this list. So ultimately, even if you do think it's going to be clinically useful for you, in real life, what you're going to do is just plug those values into a calculator and it will give you the answer. Knowing this off the top of your head is just not so helpful. So I hope, basically my plan by giving these 2 slides was to get you guys a bit more reassured, because I know so many people come to me and say, I don't understand anion gap. It worries me so much. In real life, it's not that useful. You can stick it in a calculator and you can then look up the causes. Because that's far safer than remembering this obscure area for the 1 or 2 times you might use it every few months. Then we move on to else. So we're looking through every single parameter to make sure there are no particular abnormalities. And these are some of the ones I'm highlighting because they're the ones we'll commonly look at and commonly find abnormalities in. So lactate. So above 1.5 is abnormal, or higher is worse. On a venous blood gas, it might be up to 2.6 or so, and that can be physiological. But again, you should take it in the context of what your patient looks like and how old they are and how frail they are. Glucose, so that's very, very helpful. Calcium, there is a complex calculation that you can add in where you need the albumin to do this, to work out what the calcium is on their serum, because actually on the blood gas, you'll get an ionized calcium. But what I recommend roughly is doubling it, because that's just the easiest way of doing it. And it's very unlikely that an exact calcium level is going to change your management. Roughly knowing if it's low, medium, or low, normal, or high is enough, because essentially if it's high, then you know, oh, I definitely need to send it, or low, I definitely need to send off a formal calcium or bone profile. In the meantime, I need to think about treating this. Normal ranges are often given on your gas as well, but the unhelpful thing is not many people know what the normal values is, so they don't know how much they need to worry, which is why I've suggested this whole doubling thing. You also get a HB, and sometimes you might get a creatinine. I think it's really helpful when you do get a creatinine. In my current hospital, you do, and it's just so lovely. It's inaccurate frequently, but even then, it gives you a rough idea. And finally, response. If there is an abnormality, please do respond to it. I say this because often people will be looking at the oxygen and then they'll miss the glaring glucose of 30 or the lactate of 5. You need to look at every single value and you need to respond to those values, because ultimately that's why we're doing a blood test in the first place. Every blood test is obviously something that we're doing to look at that, because it will change management. So a summary, just in case you missed any of those steps. CHARMA, C, the clinical context. H, hypoxia. Is this patient hypoxic? Are they hypoxic relative to the oxygen they're on? E.g., are they on 15 litres? And is their value not so good, given that they're on 15 litres? Is it acidic or is it alkali, the pH? Is the cause of this respiratory? Is the cause of this metabolic? And if it is metabolic acidosis, then what is the anion gap? Is there anything else wrong with the gas? Ticking off or circling every value if you need to. And then finally, what's my response as a result? We are now going to go through some cases to basically consolidate that knowledge. In the meantime, though, if you've got any questions whatsoever, I'm always open to many, many questions. Please do pop them in that Q&A box, because I will be going through all of them at the end. So please do not hesitate to ask me lots and lots of questions if you got some. So cases. Case 1, Mr. Andrews. Mr. Andrews is a 55-year-old who presents hypotensive, tachycardic with pyrexia, and he's on no oxygen. Yeah, so that's the clinical context that you want. So we're going to go through CHARMA. C, we've got the clinical context. H, hypoxia. The PO2 is normal. He's not on oxygen. We're reassured. A, is this patient acidic? Yes, their pH is 7.31. R, are they acidic because of their PCO2? I.e., is it respiratory? Well, no, their PCO2 is within normal range. Therefore, so normal range is 4.6 to 6. Therefore, I'm reassured this is normal range. Therefore, the pH is not due to this. Is it due to their base excess? Well, their base excess is low. Normal values being either -2 to +2 or -3 to +3, depending on your where you work. Okay, so this patient does have a metabolic acidosis. Their lactate is 4, their glucose is 15. I don't really need to do a anion gap. I could if I had the other parameters, but essentially this patient has a lactic acidosis. Additionally, they are hyperglycemic. So both of those things need to be addressed. But the fact that they're hypotensive tachycardic is very much the priority rather than the glucose. However, given the glucose is abnormal, you may want to do ketones just to check whether this patient has got DKA as a contribution to why they may have a metabolic acidosis. It is unlikely, though, that they have DKA, but it is worth checking for. Case 2, Miss Patel. So Miss Patel is a 26-year-old presenting with drowsiness. So again, we are going to use the CHARMA approach. She's young and she's got drowsiness. H for hypoxia. The PO2 is normal. She is on no oxygen despite the picture where you can quite clearly see she's on oxygen. She's not. So we're happy with that. A, is the pH acidotic or alkalotic? Well, it's below 7.35, so she's acidotic. R, is this due to a respiratory problem? The PCO2 is normal because normal is 4.6 to 6. Therefore, it is not a respiratory problem. M, is this due to the metabolic component? Well, the base excess is low. Therefore, that explains the pH. This is a metabolic acidosis. We could then go on to have a look at the rest of the gas, where we'd find a lactate of 4 and a blood sugar of 26. We could also find the sodium 131, potassium 4.3, the chloride, the bicarb, and we could calculate an anion gap and find that it's raised and go through mud piles. But in fairness, the lactate is raised, the glucose is raised. We're going to check the ketones. Given she's young, there's an even increased risk that this is DKA. Ultimately, it's likely to be DKA, and the anion gap does not change our management massively, but it may point us towards it if it wasn't something already on your radar. Mr. Liu, honestly, he looks quite happy, but he's not because he's unwell. He's a 68-year-old man who is presenting with shortness of breath and with a background of COPD. You already know just on the background of COPD where this is likely going. This is why I tell you the clinical context is so helpful. He's on 15 litres of on a non-rebreathed mask of oxygen and saturating 100%. I mean, you really can tell where this is likely going. CHARMA, so C, we know he's on 15 litres of oxygen. His PO2 is normal. When I say normal, I mean in excess of 40. His pH is low. His PCO2 is high, his base excess is high. So let's apply the CHARMA approach. So C, the clinical context. He has got a background of COPD and he is being over-oxygenated. I'm already worried that this patient has likely got a type 2 respiratory failure or is at risk of type 2 respiratory failure. Anyhow, let's analyze the gas systematically and think about what actually is the clinical situation. So H, hypoxia. We're happy that a PO2 of 42 whilst on 15 litres of oxygen is about reasonable in somebody who's got COPD. It's high. That's the important thing. A, the pH is low. It's 7.28. R, so that means he's acidotic. R, is this due to a respiratory problem? Well, the PCO2 is raised. Carbon dioxide is acidic, therefore we know that this is a respiratory acidosis. In this context, the base excess, the M, is high. Well, if the alkali is high, well, this is actually because it's trying to bring the pH up. It is clearly failing to do so because the pH is still low. Therefore, we know that this is a patient with type 2 respiratory failure, i.e. respiratory acidosis with a raised PCO2. The base is trying to do a little bit to compensate for it, but failing to do so. What that tells us, though, that is this has been happening for at least a day, and often 48 to 72 hours. Typically, this means the patient has got chronic type 2 respiratory failure. This is not a new thing. Their lactate is 2, their glucose is 6. I'm not particularly worried by those values, so I will ignore those values. This gentleman has got type 2 respiratory failure. What we're going to do is we're going to radically bring that oxygen down and target him to 88 to 92%. We're going to give him treatment for his COPD, and we may think about whether NIV is appropriate for this patient if he doesn't succeed with medical therapy and target saturations of 88 to 92%. Case 4, Miss Simpson. Miss Simpson is a 28-year-old female presenting with shortness of breath. She is on 15 litres of oxygen, saturating 100%. So our charmer approach, C. We've got the clinical situation. We know that she is on 15 litres of oxygen and she's not hypoxic with that. Her saturation is 100%. What we don't know is what they are without the oxygen. H. Her PO2 is normal, but in this context, her PO2 is 12. I am immediately worried. This lady on 15 litres of oxygen should be having a PO2 of really more than 40, arguably more than 60. This is bad. I'm already worried. Anyhow, we'll go through the rest. HA. The pH. The pH is raised. This patient is alkalotic. R, is this due to a respiratory problem or is this due to a metabolic problem? So R and M. R, PCO2 is low because the normal is 4.6 to 6. Therefore, this patient is alkalotic because of the respiratory problem. They've got respiratory alkalosis. Next, we will look at the bicarb. The bicarb is within, the base excess, which is a normal range. This suggests that it is not due to that. The lactate is 2 and the glucose is 6, so those are normal. This patient has got severe type 1 respiratory failure. This might be because of asthma. It might be because of a PE. It might be because of many causes of or a pneumothorax. There's lots of causes of a 28-year-old to be hypoxic like this. But ultimately, this is worrying. Even though the gas looks relatively, one would almost say, oh, this is fine. This is not at all concerning. Their parameters are quite fine. This is why the clinical context is so important, because with this clinical context, that gas is terrible. Only one thing really is properly wrong with it, although bearing in mind this and this is slightly abnormal. But this is the thing that's actually really worrying and really of concern. And next we have Miss Finch. Miss Finch is the 37-year-old female presenting with vomiting. She is not on oxygen and she's not pyrexial. So C, we've got the clinical context. H, for oxygen. So she's not on oxygen. Her PO2 is normal at 12. I'm happy. A, the pH is high. The pH is 7.48. This patient has got alkalosis. We're trying to work out why they are alkalotic. It could be due to a respiratory problem or a metabolic problem. So let's go through it and work that out. R, well, their pH is actually low. That could explain why this patient has got alkalosis. It might be that they are breathing quite heavily, possibly because of pain or possibly because of anything else. Then we look at the bicarb. Well, the bicarb, with the basic excess, i.e. the metabolic part, we find that that is high. Therefore, this patient has got a respiratory alkalosis, but also a metabolic alkalosis. We call this a mixed alkalosis or a respiratory and metabolic alkalosis. Their lactate is 2 and their glucose is 6. So this patient has a mixed alkalosis. The vomiting may be contributing to the loss of stomach acid, causing the bicarb to be high, and the patient may be hyperventilating, causing their PCO2 to be low. But we would want to check whether this patient has also got an associated respiratory disease, because if they are using the accessory muscles and they are otherwise unwell, and they need to have a very high respiratory rate to achieve this PO2 of 12, well, then the patient may be at risk of tiring, and therefore there may be that may be of concern. But overall, from this picture, we're not particularly concerned about the oxygenation here. The patient simply has been vomiting and has got metabolic alkalosis as a result. And so those were the 5 cases that I was taking you through. And I hope that you've now really understood what the CHARMA response is, the CHARMA method is. And you can again tell me if you hate this method. On the basis I've literally made it up because I couldn't find a good systematic way anywhere I looked, in any textbook I looked. And I have my own style where I don't really use the CHARMA method. But that's because I look at so many gases, I don't need a systematic way because I automatically do that. But for those who'd like a new method, here is one. C, clinical context, because that matters so much. H, is the patient hypoxic, and that's relative to the oxygen that they're getting. A, is their blood acidic or alkali, or are they alkalotic? R, is this due to a respiratory problem? M, is this due to a metabolic problem? And if they've got a metabolic acidosis, what's their anion gap? E, are any of the other parameters abnormal? And do I need to respond to any of these things that I found? This is a shameless plug, as I always and often do. This is my website, mindthebleep.com, which has an article on ABG interpretation, as well as a lovely algorithm. I might update that article to now use the CHARMA response because I actually really like it now. I've also got Twitter, so when you're tweeting out CPD me, please do include me because I'd love to read your comments, as well as an Instagram page, which is new and still needs improving, but please do follow me. And then finally, all the lovely CPD lectures that Andrew has graciously invited me to are all on my YouTube channel, so please do check me out if you do like my lectures. Finally, we hand it all over back to Andrew to ask me the many questions that you guys have hopefully popped on the system.
Dr. Akash, thank you very much indeed. I'm loving that acronym. You saw know that I'm having that. It's in my little bag of CPD as we speak, and so I'll be certainly documenting that on my CPD in a second. Lots of really, really kind comments on the chat. I'm just going to pop some links in the chat there, and I'll tell you what I'm going to do because I've just done like a little raffle thing. I don't know if you can see but we've already got some Trustpilot reviews that I can't find a box in this office talk about a paperless office. I've literally got names of people in my little scratch bag there, which I'm going to play a quick video to show you how to use the app, because I've just had about 5 messages saying, show me how to use the app. So I'm going to play this quick video, and then I'm going to give people time to either leave a review for us on Trustpilot or Google, or you can put some questions in the Q&A box, and we'll come back in, let's say, a couple of minutes. Let me just get rid of that presentation. I don't even know which button to press now. Why? See, this is what happens when the girls leave me in this office on my own. I'm not exactly sure what buttons I should even be pressing to broadcast. I think it's a big green one there that I need to press. Let me try clicking that one there, see what happens when I click this. And then hopefully this will work. Okay, so I'm going to give you a demonstration of the CPDME app. So tonight, once you've attended this webinar, you will get your certificate that will automatically come and land in the mobile app. Then all you need to do is just go in and reflect, or you can create an entry from something completely new. So if I go into my entries, you can see at the very top there, I've got tonight's webinar, breathing problems in children under 5. If I click onto there and I click edit, it's already put the title in there for me. I'm going to put in that it's 1 hour of CPD. I'm going to put in my governing body, which is HCPC, and there's lots of different governing bodies on there you can choose from. I'm going to save and continue, and this is where the magic happens. When people tell me it takes a long time to record CPD, watch this. Click onto that box and then click the little microphone at the bottom and then tell it what you want to write. So, took part in a CPD webinar this evening in relation to spotting the sick child and identifying breathing problems in children under the age of 5, full stop. Taking part in this webinar has supported me to identify some of the pathologies that will spot the sick child and allow me to manage that child either pre-hospitally, in hospital, or in the primary care setting, full stop. Having access to this useful information will support my clinical decision making and allow me to better care for children whilst in my care in the ambulance setting, full stop. Now, it might well need a bit of an amendment. I'm going to give you Andrew's top tip. If you need to go up and change a word, press the space bar and keep your finger on it, and it now turns into a mouse. It's like magic. You can go to any word and you can amend or change it. So I'm going to change a particular word, keep my finger on the space bar, and I'm going to go down to manage, and I'm going to go delete, 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 or let me click on that again and change that to support. And then I'm going to click on to save and continue. I'm going to select my HCPC standards, click on to save and continue again. My evidence is already there. You can see down in the middle, my CPD evidence is there. If I click on it, the certificate is there. It's a bit weird, it's got my name on it and I wrote the certificate at the bottom, but hey-oh. And then I'm going to click save and submit. Once I've done save and submit, actually you can see at the very top of there, I've got my entry. It's 88% complete, 1 hour of CPD. If I click on it and click preview, you can see a print ready copy of my diary entry. What have I done? Why have I taken part? How is it going to change my practice? And if I scroll up, you can see my certificate. And when it comes to wanting to print all of this off in a perfectly formatted PDF or digital copy, I simply just go to cpdme.com, probably the same place as you went to register for this webinar. So download the app and make your CPD simple. In fact, I guarantee you, if you can find anywhere that records CPD easier and produces it in the most perfectly formatted print body format, I'll give you your money back. I'm that confident, and I'll send you a cup once they come back into stock. So please do download the app. As I said, for those people who do get the certificate for tonight, the app will notify you when that certificate comes into your portfolio. So again, you just need to go in and just literally edit what's happened. And then what have you learned? Why have you learned it? And how is it going to change your practice? It's really as simple as that. A couple of upcoming events before we go to Q&A. We have got an amazing event next weekend. I am so excited because it's just before I go on holiday. But if you haven't done so already and you have an interest in trauma, then we have got a 2-day physical learning event, which is the Foundations in Trauma course. That is down at Yarnfield Park, and it's £120 for 2 days by our sponsors and friends over at Trauma Care. It really is 2 days of full packed hands-on learning, no boring lectures. It's literally 10 minutes of theory versus 40 minutes of hands-on practical, and you've got scenarios such as major incident management, collapses, trauma, bleeding, you name it, it is all there covered for 2 days. So whether you're a newly qualified professional student in healthcare or you've a bit of an old dog like myself who just wants to brush up on some new tricks, then that will be an amazing event. And that's got about 14 places left on the Saturday and Sunday next weekend. So if you've got it off and you've got nothing on, maybe get yourself down to that event. Scan that QR code. We've got a Introduction to LGBTQIA by Phil Harper, and that's on the 7th of December, talking about microaggressions for health and social care professionals. So please do scan that QR code or jump over to the CPDME website. If you have got the app, you can register for webinars with one single click. So that's another good reason, really, to download the app. Ta-da! Is back. Our Dr Akash and also our Dr Chris Jeffries on Saturday the 11th of December talking clinical history taking, and Dr Akash will probably we'll have a little chat actually at the back of this back of Q&A, but we're going to cover clinical history taking from all walks of life, geriatrics, paediatrics, primary care and such, and that event is for members of CPDME £4.99, and for non-members it's £9.99, so it's half price, and that is from 9 o'clock till 1 o'clock on Saturday the 11th of December. So that's a fun packed Saturday morning symposium. I'll provide the breakfast, just need to get your ticket and turn up. And our last one for this evening before we go to Q&A is Ben Splashett on the 16th of December, pre-hospital ECGs part 1, the principles. So if you just want to brush up on ECGs and the basics, please join Ben on the 16th of December by scanning that QR code. I always teach my young students, always good to cover the basics because it's sometimes you forget. It's all right identifying your posh rhythms like your Wolf Parkinson Whites and your Torsade de Poix, but actually reversing back to the basics is sometimes exceptionally useful. So, Q&A, Dr. Akash, are you there? Of
course.
So Sue is asking, how do we know it's been going on for a while? I'm presuming she means the acidosis.
Yeah, I think she's clarified on her second question.
She has.
My case was regarding case 3 in type 2 respiratory failure. Very good question. So essentially, we know that it takes a while for the kidneys to allow for this compensation, i.e. for the bicarb or the basic cess to increase. And so if you find that the bicarb is high, then you know that this is a chronic type 2 respiratory failure.
Dr. Akash, thank you very much. You've done amazing tonight. You've managed to get away with 2 questions, which is at least to say fabulous. Haley's put, if anybody's struggling with ABG, then search for ABG Tic-Tac-Toe. Quite useful. Thanks for that top tip, Haley. We have got Mick, who's put, thanks, Dr. Akash. Presentation has improved my understanding of ABG. Keep charmer. It has worked brilliant. And lots of other very useful links up and above that. So let me stop my screen share and we'll do the raffle. Yeah? Are you ready for this, Dr. Akash?
Oh, yeah, definitely.
I love a raffle. I do love a raffle. So let's have a look who I've got in my magic little bag. Let me just stop my screen share. Stop that. And we'll just go on cameras. So we'll do 2 books tonight and we'll do 2 books tomorrow. So I'm going to do a little shake. And then I'll tell you what we'll do. Because I've got the list of delegates up. So if your name is read out off one of these pieces of paper in this box, then I'll try and unlock your microphone and we'll go live, and then we'll ask you which book you like. Does that sound like an option? So let me log in here and we'll pull one out. Make sure you can't. So I'm not cheating. I've rolled my sleeves up, you see, like a real magician. Are you ready? Katie Murray. Are you there, Katie? Are we online still? You've got to be in it to win it, Katie. She's here. Shall we allow Katie to talk? Is she still there? I think she's just gone offline. Maybe? No? Yep. Katie, are you there? Can you hear us, Katie?
She said yes in the chat.
Did she? I don't. You might have your microphone on mute, Katie. Can you hear us?
She's trying to turn her microphone on.
Oh, well, I'll tell you what, Katie, what we'll do, if you're in the chat and you can hear us, don't worry about it. Just tell me which book you want, and then you just need to drop me an email with your address and we'll get it sent to you. So do you want the pre-hospital care manual or do you want the clinical skills introduction? Take your pick and I'll get it out to you. Don't worry if you can't turn your microphone on. Clinical skills, please. Perfect. Katie, drop me an email, please. Andrew@cpdme with your full name and address, and I'll get that in the post for you tomorrow. Special delivery, of course. Katie, thank you very much indeed. Don't worry if you can't get your microphone working. We'll be fine. We'll be fine. Let's do another one. Are you ready, Dr. Akash?
Very excited. I wish I could reach out and like pick it because I feel like I should be picking one of them.
I'll drop one out then. Let me do another shake. I'm going to have to get a tombola machine, I think, aren't I? Do you remember the old tombolas? You put a cork in there and you maybe I'm just showing my age.
Yeah, sorry, that reference is lost on me.
I saw you just glaze over. You just absolutely glazed over.
So sorry, Andrew.
Rebecca Eden, are you there, Rebecca? Let's see if you're in the list. Let's have a look. Where are you? Rebecca. Ah, she's there. Allowed to talk. Let's see if we can get Rebecca online. Rebecca, are you there?
Hi there.
Hey! Hey! It's like almost like you've run a cruise around the world, Rebecca, but you haven't. You've won a book. And so,
Brilliant.
So pick your book, Rebecca, live. Which one would you like?
Oh, clinical skills, please.
Clinical skills, perfect. Rebecca, if you drop me an email to andrew@cpdme.com, I will get that book in the post for you tomorrow, and I'll also put some other goodies in there for you to enjoy.
Oh, thank you so much. That's brilliant.
There you go. You got to be in it to win it, Rebecca. Thank you very much indeed.
Absolutely, thanks.
Take care. Bye-bye. Ta-da! So what I will do is I'll give people a chance to still leave a review. If you haven't done so already, please do so. And I will make sure I pick 2 more people tomorrow and I'll launch it live on social media. Dr. Akash, thank you so much for this evening.
Should we take a moment to talk about the history taking symposium?
What a good idea. What a good idea. So Saturday, oh gosh, I can't remember the date now. Is it the 11th?
The 11th of December, yes.
It is. I'm like a goldfish. Saturday, 11th of December, 9 o'clock till 1 o'clock. Ticket prices, $9.99 for non-members, $4.99 for members. Let me pop that back up on the screen because it'd be useful to share it for those people who might not have seen it first time round. Let me share my
I cannot
screen.
stress that all of you guys should attend because I'm going to be giving a lovely session as well as Chris where we go through all of the key questions and all the most important questions that you can ask on a history, all the really high yield stuff and all the things that you're constantly asking us to do. So please make sure that you join us on that day because essentially we're guided by what you guys want. And if there are any other things that you'd like or if there's anything particular that you'd like from that session, just let us know. We're more than happy to, at least I'm definitely more than happy to make it a session that's worth it for you.
Fab. So I'm an experienced practitioner, Akash, and I would think I'm pretty good at clinical history taking because I've worked in ambulance emergency care, I've worked in primary care, I've worked in secondary care. What top tips am I going to pick up from attending this Saturday morning event that I probably don't already know?
So ultimately, the difference would be that when a patient's coming in through the medical take, there are some key questions that I ask that really help me identify which are the patients that need to be in hospital that I need to look after, which are the patients that can manage at home. And that varies. So what we're going to go through is pediatrics, the elderly, surgical, medical, essentially all of the kind of 4 massive groups that all of you guys see. We're going to go through the key questions to ask, which will help you make that decision, which will help you feel more confident in what your underlying diagnosis is. And also, we all know that if you've got chest pain, you ask Socrates, these are the key questions you go through. But actually, which of those questions are really helpful? Which of those questions are going to change your management? Which of those questions is going to make you think, this is the diagnosis. Well, that's the advanced level of skill that I think that all of you will get from attending that webinar.
Dr. Akash, thank you so much indeed. I'm actually looking forward to it. It's a Saturday morning that I normally have the team in here, and one of them bakes breakfast for us all, including freshly baked bread. So I tend to love the Saturday morning symposiums. So if you haven't got a ticket, please do so. $4.99, cheap as chips, and I guarantee you will take away some top tips. You've also got a previous webinar that I think is on our website from a symposium on interpreting blood test results. That also is equally useful. So when you jump onto the website, you'll see at the very bottom that you can also access that information. All that leaves me to say is thanks very much. David has got, he's just bought a ticket or did buy a ticket. Yes, David, you will get your login details closer to the day, so we'll send them to you. But thank you so much indeed for getting a ticket. On behalf of myself and all the team here at CPDME, Dr. Akash, thank you so much indeed.
Thank you so much for having me.
And remember, ladies and gentlemen, if you are out there working tonight, stay safe, and thank you very much for your hard work and dedication. If you are not working tonight and you're at home, kick off your slippers, enjoy the rest of your evening, maybe pour yourself a cup of tea, cup of coffee, hot chocolate, or maybe even a glass of wine, and enjoy the rest of your evening. But thank you for supporting CPDME, and stay safe. Take care, everybody. Thank you.
Lovely. Thank you so much.
Night. Night.
Bye.